Okay, Amit, maybe we can start with introduction and the talk.
Absolutely. All right, thank you everybody for joining. I know this was a little bit of a short notice on the announcement, but hopefully you'll catch this on the recording. This is a CME event, as you all know, and if you are not aware of ALAPIO, as most of us are aware of ALAPIO, ALAPIO is a nonprofit organization. You can find more information on alapio.org, where you can donate to provide medical help to low-income folks in Southern California. So one of the things that you know about me is that I work with people that have hearing loss and tinnitus and almost anything to do with ears. Well, recently there was a study put out that the top 3 most common health problems in the United States, number 1 was cardiac disease, number 2 was arthritis, and number 3 was hearing. So a lot of the hearing losses that we see, a lot of them cannot be cured with medications. We know that there are some that can be helped. We know that a lot of our patients can be helped with hearing aids. However, there are hundreds of thousands of people in the United States that actually cannot be helped with hearing aids. And some of those folks have very severe to profound hearing losses, including some very low discrimination scores, which occurs more in the temporal lobe of the brain. So for a lot of those patients, we're very conservative in choosing those patients. We go down the road of what's called a cochlear implant surgery. So a cochlear implant, as you may or may not know, there's a function of it that is actually on the external part of your head and ear. And then there's an implanted electrode array, which gets implanted into the inner ear. But you're not here today to hear me speak about cochlear implants. I'm very honored to be able to introduce our speaker today, Dr. AKIRA ISHIYAMA. And I'm sorry, I'm going to read this introduction here. He is actually at UCLA as an otologist and neuro-otologist. He received his medical degree in 1990 from Northwestern Medical School. He completed his internship and head and neck surgery residency training at UCLA. In 1997, Dr. Ishiyama was appointed to the faculty in the UCLA Division of Neck and Head Surgery to cover the service at Olive View UCLA Medical Center. In 1999, Dr. Ishiyama became chief of the Olive View UCLA Head and Neck Service. In June 2008, Dr. Ishiyama was given an accelerated promotion to full professor in UCLA Head and Neck Division. He's actively involved in the research projects on Meniere's disease and human temporal bone pathology. He is a director of the Victor Goodhill Human Temporal Bone Laboratory at UCLA, and he has been funded by the NIH NIDCD. Currently, Dr. Ishiyama is working on the vestibular pathology in Meniere's disease to understand the disease mechanism. He is the director of the UCLA Cochlear Implant Program, which is recognized as one of the centers for excellence in California. And of course, on a side thing that he's also doing, he started a cochlear implantation program in Armenia back in 2004, so he's doing great work there. He's mentored a long list of students and residents in his lab and in the clinical arena, where he maintains an active practice in all aspects of otology and neuro-otology, ranging from balance disorders, cochlear implantation, pediatric otology, facial nerve disorders, acoustic neuroma, and skull-based tumor surgeries. In our clinic in Woodland Hills, Dr. Ishiyama is our surgeon of choice for those patients who require cochlear implants. So please help me welcome Dr. AKIRA ISHIYAMA.
Thank you, Dr. Amit, for the generous introduction. Today, what I wanted to talk about initially is what we do using the archival human temporal bone specimens we have at UCLA. We probably now have the largest collection of human temporal bones in the world at UCLA. About 6-7 years ago, House Institute went bankrupt, and we have consolidated their collections. And we also now take care of the temporal bone specimens from the University of Chicago and Wake Forest and Henry Ford. So we have large depository of human temporal bone specimens. And I started doing some human temporal bone studies using temporal bone specimens from patients who had received the cochlear implants. And we have started making some objective measurements to see what we can do to help these patients better. So the first thing I wanted to talk about is what we are doing in the research lab and see how we can improve the outcome of our patients who need to have this technology. Then I would like to talk about where we stand, what we can do to improve the awareness for those who actually need this technology. And this is my disclaimer. First of all, when we talk about placing a foreign body cochlear implant in the inner ear, we need to know what we are stimulating so that patients who are hard of hearing could actually perceive the auditory information. Within the cochlea, we have neurons, primary afferent neurons, located within the center of the cochlea called spiral ganglion neurons. So the first question that came to mind is, in using the human temporal bone specimens from patients who actually have deafness and require cochlear implants, how far do these neurons extend? More and more implant surgeons are now doing cochlear implant surgery, placing the electrode from a structure called the one window. And the question is, how far does the spiral ganglion neurons extend, and what do we know about this? Obviously, the indication of cochlear implantation has changed drastically since 1980s, when the first surgery was conducted. Electrodes are different, indications are completely different today. More and more patients are getting implanted with what we call residual hearing. So we have patients who have substantial hearing remaining within the lower frequencies, but they have lost their hearing in higher frequencies. Sometimes you see that with genetic form of hearing loss or aminoglycoside toxicity. And we can actually combine the use of hearing aid and a cochlear implant in the same patient. The goal of hearing preservation cochlear implant, that's how we call it, when we do both the application of hearing aid and the cochlear implant, is called EAS, or electroacoustic stimulation surgery. And the goal is to place a cochlear implant electrode in the human ear without causing much structural disturbance. And the long-term goal is to see, obviously, we're placing a foreign body within the cochlear, and we want to see minimal secondary changes in the form of fibrosis or ossification. Now, cochlear implant electrode is refined, it's a very small structure. However, you cannot really feel the resistance when you place the cochlear implant in the inner ear, because it takes only 80 micronewton to translocate, meaning you can penetrate the basilar membrane, which is a fine structure we have within the inner ear. So we need to have a better way of guiding the surgeons. So these are general ways we can have electrode-related complications in the human inner ear. If you have some form of obstruction, you can have an incomplete insertion, kinking of the electrode, or tip of the electrode could fall over, or, as I mentioned, scalar translocation, where the basilar membrane gets penetrated by the electrode, or the electrode could get pushed out, called the electromigration. So in 1989, using 2 temporal bones from a patient who, these are autopsy specimens. This study was done in the San Francisco area, and then they determined that in the human, the spiral ganglion neurons extend up to 630 degrees, but they didn't take the measurement from the one window. And human ear has 2.5 turns. So what's important to realize is that spiral ganglion neurons, that's designated in green on this picture, it ends here, and all the projections that occur on the top are in the form of dendritic projections. And the Carano, 1996, in Sydney, conducted a study using 8 autopsy specimens, and he did a manual reconstruction. Again, he didn't take a round window as a point of reference, and he determined that spiral ganglion neurons extend up to 630 to 720 degrees. So what we did was to take our human temporal bone specimens from the lab, just to give you an overview. When somebody passes away, we go immediately to the autopsy room and harvest the temporal bones, and these human temporal bones are decalcified. It takes about 12 to 18 months to decalcify. Then we put the bones in a celloidine, and they are sectioned at the 20 microns, and only 10%, every 10th section gets stained, and the remaining 9 sections are stored in the alcohol. So what we did was we aligned these two-dimensional H&E sections and used a computer software called AKIRA and did 3-dimensional reconstruction and used round window as a point of reference. And we mapped out how far the human spiral ganglion neurons extend. Then the second thing we did was to take a measurement by selecting a point along the inner wall of the cochlea, because there are 2 different forms of cochlear implant electrodes. One of them is called the perimodiolar, where the electrode wraps around the inner wall of the cochlea. And there are other types of electrodes called the lateral wall electrodes, where the electrode is sitting along the outer wall of the cochlea. So we took several measurements. So we looked at 15 bones, ages ranging from 60 to 92 years of age. And this is a summary slide. In the human, measuring from the round window, the spiral ganglion neurons extend to a pretty narrow angle, 684 to 704, or approximately 700 degrees, measured from the round window membrane. Now, if we were to cover the linear distance of these spiral ganglion neurons, if we were to place an electrode along the medial wall, it takes approximately 18 millimeters. But if you were to cover the same linear distance using an outer wall electrode, it takes 35 millimeters. And we then looked at the overall cumulative linear distance in terms of spiral ganglion neuron coverage from 0 to 90 degrees, measuring again from the round window. And we have determined that if you put an electrode measuring approximately 60 millimeters around the inner wall of the cochlea, it captures 90% of the linear distance of spiral ganglion neurons. And in order to accomplish the same coverage using an outer wall electrode, you need to have 31 millimeter electrode. Now, apical 26% of the cochlear duct is not sitting adjacent to the spiral ganglion neurons, because the spiral ganglion neurons end around 700 degrees of insertion angle for the round window, and anything that goes beyond that is dendritic projections. And these are multiple measurements that we have taken. And I'm not going to go over that in details. So as I mentioned, it takes about 18 millimeter to cover the entire spiral ganglion neurons. If we were to go perimodiolar electrode along the inner wall of the cochlea, or 34 millimeters for 100% coverage. Now, we collaborate with a group in Uppsala, Sweden, and Smith Agrawal in Western Ontario, Canada. And we have captured our temporal bone imaging using a synchrotron imaging. And we have actually duplicated our 3-dimensional finding using a different imaging studies. Now, here comes the interesting part. When you look at the marketing language of different companies, there are 3 major electrode companies that sell the cochlear implant electrodes in the United States. Med-El, for the Medical Electric from Austria, Cochlear Corporation from Australia, and Advanced Bionic from Valencia, California. It gets very confusing because they will tell you our implant is superior because the electrode length is much longer, therefore it has much better cochlear coverage, but that is not the case. Depending upon whether you're taking inner wall in the form of a perimodiolar or lateral wall electrode, it changes drastically. And there is an electrode made by a company called the Cochlear Corporation, and the most recently introduced, one of the most recent electrodes brought in by the market is called the CI632, and this electrode has a linear distance of 60 millimeters. As I demonstrated earlier, if you put 16 millimeter of electrode around the inner wall of the cochlear, it captures 90% of the linear length of the electrode. But in order to accomplish the same linear coverage, you need to have a 31 millimeter coverage. Now, we are beginning to do more and more hearing preservation surgery for those who have residual hearing. Sometimes the hearing remaining in the lower frequencies are quite good. Sometimes it's completely normal, and then rapidly you taper off in the mid and high frequency zones. And there is a conversion function called the Greenwood function, and 1000 hertz is it corresponds to 360 degrees of insertion angle. So this is a very important function to know when we select the electrode for patients. So first turn, 360 degrees, again corresponding to 1000 hertz. If we were to put the electrode, it's 14 millimeters. And if we were to put the electrode around the inner wall of the cochlea, this captures 80% of the linear length of the spiral ganglia neurons. So outer wall, if you were to put the lateral wall electrode, you need 24 millimeters, but this captures 70%. So it's much more efficient to place the electrode along the medial wall of the cochlea. Now, the story gets a little bit more complicated because depending upon which specimen or which type of hearing loss you have, the spiral ganglia neuron distribution is quite heterogeneous. So we looked at the density of neurons at different locations, and out of the 15 bones, we didn't see any regional differentiation in the 8 specimens. The 1 out of 7 bone had higher preservation than apical turn, and then we have 1 bone out of 7 with higher preservation is a basal turn, and the 5 out of 7 had higher preservation, apical and middle turns. And the other thing we noted was regional variation does not necessarily indicate a higher degree of overall preservation. Now, this is an interesting slide, I think. One of the things that we wanted to see is, suppose you have a lateral wall electrode, 20 millimeter electrode or 22 millimeter electrode. If you insert the same length of electrode in a human inner ear, depending upon who the recipient is, the electrode travels differently. Some patients have different pathology within the inner ear. Therefore, the degree of insertion angle differs even for the same length of electrode. So the story is much more complicated than simply transferring the linear distance to the neuronal coverage. So this is one of the studies we have done to basically prove that round window insertion is preferred over the cochleostomy. In the past, in order to place an electrode in the cochlea, we made a physical opening, a separate opening within the cochlea as indicated in B with the arrow. So we take a drill and drill a hole in it. But if you look at the secondary changes within the cochlea, you can see tremendous amount of fibrous changes, and that these darker areas indicate new bone formation, and that this has adverse effect. I'm going to demonstrate it to you shortly. On A, this patient received the cochlear implant through the round window, And there really isn't secondary osteogenesis, and the inner ear looks much cleaner. And this is from a patient who actually had electrode inserted in the scala vestibuli, which is right here on the top. When we do this implant surgery, we try to put the electrode at the base, called the scala tympani, but no matter how carefully we conducted the surgery, there are situations where the electrode end up in the scala vestibuli. And in this case, you can see distension of a structure called the rhizinous membrane, and this is due to the fibrous capsule obstructing a structure called ductus reunions, and demonstrated secondary endolymphatic hydrops. So this is a case where a patient had cochleostomy, but there was a very limited fibrosis and osteogenesis. And in this particular case, it did not involve a structure called ductus reunions. Therefore, there was no evidence of secondary endolymphatic hydrops. And these studies that we had conducted about 5 years ago was the motivation for most of the high volume surgeons globally to abandon the cochleostomy and place the electrodes in the round window to minimize the secondary changes within the cochlea. So then the other thing we did is to see if there is any evidence of injury within the cochlea. What type of patterns do we see? So we looked at 22 bones from 19 patients, and we categorized those bones in 3 groups. One is called the localized translocation. Second group was called lateral wall injury with the translocation, and cases where we didn't see any secondary changes. So we also looked at the histology with a 3-dimensional reconstruction. And one thing we found is when there is evidence of translocation, it appears to occur at the 180 insertion angle, measuring from the round window. It's a very consistent pattern. And when we looked at the speech perception studies, we found out that if you have a very small localized translocation, the speech perception data is significantly better compared to patients who had much more global intercochlear injury. So this is one example of a patient who actually had a localized translocation. You can see here, this is where the electrode pierced through the scala tympani to scala vestibuli. And this is the center of the cochlea. This is the area where we have neurons called the spiral ganglia neurons. And the appearance of the spiral ganglia neuron is pretty good. And indeed, this patient did quite well. On the other hand, if you have much more global injury to the inner ear, in this case, patient had a cochleostomy, and you can see tremendous osteogenesis with the fibrosis, and this asterisk here indicates where the lateral wall was completely stripped off. And you can see the evidence of endolymphatic hydrops in the mid-apical turns. One thing which was also interesting is that out of all the electrodes we investigated in a series, as long as the electrode was shorter than 20 millimeters, there was not a single case of translocation that we could detect. Therefore, the length of the electrode clearly had significant outcome to dictate the degree of intercochlear injury. And about a month ago, Cochlear Corporation came out with a brand new electrode called the CI624. And interestingly, the length of the electrode is exactly 20 millimeters. So it matches with our temporal bone studies. We also noted that when you place the electrode through the round window, you have much less incidence of translocation, which means electrode stays within the scala tympani much less chance of causing secondary changes in the ear. And deeper angle of insertion exhibited a higher degree of inner ear damage due to translocation. Now, we're going to change the talk a little bit. One of the most important things that's been coming out over the last couple of years is, what do we know about the outcome of pediatric cochlear implants? All the babies born in the United States, approximately 98% of the babies born in the United States go through what we call newborn hearing screening. The purpose of identifying patients at the earliest point in time in life is, if a baby has hearing loss, we can prepare the kids for possible intervention to to provide better speech performance. The brain has a critical period of time to hear and process a sound for us to acquire and develop the language. Language is a foundation for us to develop complex and abstract thinking skills. So if you do not have a form of language, you cannot read, you cannot process complex scientific or mathematical concept. Therefore, it's critical, it's so important to detect the presence of hearing loss if such disability is present at the earliest possible point in time. There is a well-known longitudinal studies conducted from Australia called the LOCHI, L-O-C-H-I study, which means learning from the longitudinal outcomes of children with hearing impairment. What they found is, if you identify the deafness early and place the cochlear implant, we're not talking about the detection of deafness. We actually place a cochlear implant and activate the implants at age 6 months. You are much more likely to do better in terms of speech perception compared against kids who received the cochlear implants at 12 months of age or 24 months of age. And when you look at the difference in standard deviation, it's enormously different. So one of the important things to do is, once the child is born with, once the child failed the newborn screening, the child needs to be referred to a tertiary care center without any delay, and intervention plan needs to be started without any delay to maximize the speech perception outcome for the kids. Unfortunately, in many countries, including the United States, this doesn't always happen. And that we continue to work together to see what we can do differently to help our kids. And that's why we need all of your help in this regard. The cochlear implantation has evolved drastically over the last 30 years. The first cochlear implantation was approved by FDA in 1984, where patient at the time needed to have bilateral deafness. We're talking about profound deafness. And at the time, only one cochlear implant was allowed to be performed. 6 years later, in 1990, we changed the indication to unilaterally implanting bilateral deaf kids. So now we're allowed to do surgery only in 1990, but the age cutoff was 2 years of age, because at the time, there were serious concerns to perform surgery in younger kids. Now, in 2000, 10 years later, the age was lowered to 12 months. At the time, the FDA indication still said unilaterally implanting bilateral deaf kids. In 2002, bilaterally implanting patients with severe to profound, so indication got widened a little bit. It didn't need to be profound. Now, starting 2014, we are now implanting patients with residual hearing. And starting summer of this year, several months ago, the FDA changed the indication to less than 9 months of age for kids. And you could have single-sided deafness, meaning you can have completely normal hearing on one side, and if you have deaf ear in the contralateral ear, you can now get a cochlear implant. So indication is changing, and this continues to change. Hearing loss, as Dr. Amit said, indicated at the very beginning of the talk, is a serious health issue. WHO stated that 466 million people have disabling hearing loss. By 2050, it is expected to rise to over 900 million, meaning 1 out of 10 people would have hearing-related problems. And 1 out of every 3 people over the age of 65 are affected by hearing loss in the US. Therefore, Dr. Amit is absolutely right. Hearing loss is a major public health issue. It's the well-known study, Franklin from Johns Hopkins found that untreated hearing loss increased the risk of developing dementia by 50% and depression by 40% in just 5 years when compared to those without hearing loss. Now, nearly 38 million individuals in the United States have untreated hearing loss, which is a large number, which is associated with cognitive and functional decline. So hearing loss could have tremendous implications, not only for the language, understanding, and communication, but it has other implications as well. Now, as Dr. Mead was indicated at the beginning, in order to provide cochlear implants for patients who actually qualify for cochlear implantation, it's so important to do the surgery earlier than later. In other words, you cannot really push the hearing aids to the limit to the point where you're absolutely desperate. You cannot hear much of anything with a conventional hearing aids, then switch over to surgery. We need to do much better because science clearly shows that earlier point of intervention translates in much better speech perception. And the advantage of combining acoustic hearing and electric stimulation is well defined. And the advantages are how well you can hear in the presence of background noise, you can localize sounds better, and also music appreciation much better with this strategy. And there was a interesting article published in the New York Times, December 31st, 2018, and it says, hearing loss threatens mind, life, and limb. So it's not simply a matter of communication disorder, it has a lot of other implications. It has relationship to the change in the cognition. A lot of the patients who have hearing loss are depressed, they're isolated, they do not want to feel embarrassed because they often need to ask what others are saying repeatedly. And there have been studies indicating that people who have more hearing loss are much more likely to have falls. If you have hearing disabilities, it's going to affect your ability to work. And you're going to be dependent on others since you're not going to be able to function with the hearing loss at the same level. And social isolation is a major issue. So it has a lot of additional disability and implications. In order to prove that earlier point of innovation with a cochlear implant is important, we went to the lab and stained our human temporal bone specimens from, again, patients who had received cochlear implants with a molecule called the BDNF. It's called the brain-derived neuronal factor. So what you see here is the unit reactivity of neurons from a patient from the unimplanted side. So in the past, when a patient had bilateral profound hearing loss, they usually chose the ear with worse hearing for surgery. So slightly better ear was not implanted, and they usually place a hearing aid. So this is the side obtained from a better hearing ear compared to the contralateral implanted ear. But as you can see only basal level, minimum level of immunoreactivity. However, this is from the same patient who had received cochlear implants in the ear with worse hearing. But as you can see, with the provision of electric stimulation, the BDNF activity is significantly improved. So just as demonstrated in the animal models, in the human as well, earlier point of electric stimulation to the spiral neurons significantly elevates the functionality of the neurons. So globally, how commonly is this procedure performed for those who would benefit from it? And it's surprising to see that the market penetration rate is still very low. And we all need to work as a healthcare providers together to improve the awareness. For example, in the US, approximately 5% of the patients who actually benefit from the cochlear implants are being implanted. That means there are 95% of patients who should be considered for cochlear implant surgery who are not getting implanted. And Germany is 4%, Japan is only like a 1%. So we all need to work together as a healthcare provider to improve the awareness of this technology for the patient who need it. Now, in order to improve the awareness of cochlear implants together, I think it makes more sense to work to partner with the community hearing healthcare network, and that's what we do with Dr. Amit. And we need to also educate more patients and also the healthcare providers. We need to actually educate young medical students and residents and physicians about how important the hearing related matter is for overall health. And we need to also improve the awareness of cochlear implantation for patients with a hearing impairment. And also, the cochlear implant, the referral criteria is pretty confusing for many. And I think it's important to work together to make the referral much easier to tertiary care center like us or Dr. Amit, who are equipped to do much more sophisticated speech perception testing to see whether a patient should be considered for cochlear implants. Now, this is a slide that talks about what happens as you begin to have hearing loss. As the decibel loss, as the degree of hearing loss increases, the benefit from using a hearing aid declines. Now, if you were to put the cochlear implant at this point where hearing aid doesn't work any longer, and at the point where things are so desperate, you get the cochlear implant, the maximum benefit you could achieve at that time is going to be rather limited. The reason is, with the progression of hearing loss, you're going to have degenerative changes of the neurons. Not only the neurons, you're going to lose all the dendritic projections. However, if you could identify patients earlier where a patient could benefit from cochlear implants while the patient still have some residual hearing, we know that the earlier innovation is much more beneficial for the patients. And this lag time is called the essential time. And one of the reasons why I believe I'm giving this talk is to improve the awareness for those who treat patients with hearing disorders, but also others who are not treating patients with a hearing loss on a day-to-day basis. But if you notice somebody who is struggling, even within your family, your patients, your friends, they need to be referred for better testing to see what options they have. So this is the end of my talk, and I'm happy to answer any questions you may have.
Thank you so much. That was actually very, very good. To add a little bit to that, not that we're expecting this to happen, but on the 28th of October in our office, we're actually doing a full cochlear implant day. So we'll be evaluating numerous patients to learn the process a little bit better as well. So if you are familiar with any patients who have very severe and profound hearing losses, of course, please do let me know.
Great, thank you.
Open it up for questions, of course.
Yeah, this is Raj Gupta. Though I'm not from a medical background, I'm from a science background. First of all, this talk was very interesting. I really enjoyed. And my question is this electrode transplant, how expensive this surgery is? And is there any age limit on it?
There is no age limit. There's no age limit at all. The cost of the implant, the electrode itself, the hospital pays about $28,000 per electrode. And if you were to do surgery, most of these surgeries are done on an outpatient basis at the outpatient surgery center. And the cost of the entire package is about $50,000 to $60,000.
I see. And I'm sure that kind of surgery is probably not covered by Medicare or any insurance.
It is.
Oh, it is? I see. Interesting. So Medicare does cover this?
Yes.
Oh, thank you.
And Medicare, in fact, even Medi-Cal, I believe, has a program as well, correct?
Yeah. Medi-Cal covers it. California Children's Services covers it. Medicare covers it. But the Medicare guideline is a little bit more rigid. In general, you need to have a profound hearing loss, severe to profound hearing loss in both ears. At this point in time, they cover 1 ear, one side only. But it appears that if you space it apart, you can do surgery in the contralateral ear as well.
What is the oldest patient you had done cochlear implant surgery?
That's a good question. I had a professor of biochemistry who was still working actively at age 94.
Oh.
Interesting. That's really outstanding.
We thank you, Dr. Akira, for sparing your time and explaining it to us. You are a scholar and a gentleman.
Thank you very much.
Thank you.
Thank you.
Good night, everybody.
Good night.
Good night.